So the adrenal glands are divided into two major parts, the cortex and the medulla. The adrenal cortex secretes glucocorticoids, mineralocorticoids, and androgens. The steroid hormones are synthesized from cholesterol through a series of enzymatically catalyzed steps. Now coming to the regulation of the RAS system, there is circulatory plasma volume. Then, which if it decreases, there is a decrease in the renal perfusion pressure, which stimulates the juxtaglomerular cells. There is renin release, which converts angiotensin 1, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by ACE. There is angiotensin converting enzyme which is present predominantly in the lungs. Angiotensin 2 causes activation of angiotensin 2 receptor 81, which stimulates aldosterone release, which leads to renal sodium retention and potassium excretion. Activation of angiotensin 2. Angiotensin 2 is a potent vasoconstrictor which will further increase the renal perfusion pressure. Cushing syndrome was named after Sir Harvey Cushing, who described the syndrome in 1912. Excessive production of adrenal glucocorticoid results in a characteristic combination of clinical features. Though Cushing syndrome is an uncommon illness, it has high morbidity and mortality if untreated. This is mainly due to increased risk of cardiovascular disease as well as infections. Therefore, early diagnosis and treatment is essential. Causes of Cushing syndrome: ACTH dependent Cushing's and ACTH independent Cushing's. ACTH dependent Cushing's is Cushing disease, that is ACTH producing pituitary adenoma. Ectopic ACTH syndrome due to ACTH secretion by bronchial or pancreatic carcinoid tumors, small cell lung cancer, medullary thyroid cancer, and pheochromocytoma. ACTH independent Cushing is basically by the adrenal gland, that is adrenocortical adenoma or adrenocortical carcinoma. Rare causes are macronodular adrenal hyperplasia, primary pigmented nodular adrenal disease, or McCune-Albright syndrome. At least 90% of the patients with Cushing disease, ACTH excess is caused by a corticotrope pituitary microadenoma. Pituitary macroadenoma is tumors greater than 1 centimeter in size, which are only seen in 5 to 10% of the patients. Pituitary corticotrope adenoma usually occurs sporadically, but very rarely can be found in multiple endocrine neoplasia 1, that is MEN1. Pituitary adenomas constitutive of Cushing syndrome frequently harbor mutations in the ubiquitinase USP8, which leads to constitutive activation of EGF signaling and consequent upregulated expression of the ACTH precursor of POMC. Signs and symptoms of Cushing syndrome: body fat, it causes weight gain, central obesity, rounded face, fat pad on back of neck, that is buffalo hump. Skin, there is facial plethora, thin and brittle skin, easy bruising, broad and purple stretch marks, acne, and hirsutism. Bone, it causes osteopenia, osteoporosis, which causes vertebral fractures, decreased linear growth in children. Muscle, there is weakness, proximal myopathy, prominent atrophy of gluteal and upper leg muscles with difficulty in climbing stairs and getting up from a chair. Cardiovascular system, there is hypertension, hypokalemia, edema, and atherosclerosis. Metabolism, there is glucose intolerance, diabetes, and dyslipidemia. Reproductive system, there is decreased libido in women amenorrhea due to cortisol mediated inhibition of gonadotropin release. Central nervous system, it will cause irritability, emotional liability, depression, sometimes cognitive defects. In severe cases, it causes paranoid psychosis. Blood and immune system, increased susceptibility to infection, increased white blood cell count, eosinopenia, coagulation with increased risk of deep vein thrombosis and pulmonary embolism. This is centripetal obesity with purple stripe. Then this is purple stripe. Then this is easy bruisability of the skin, and there is hyperpigmentation of the knuckles in a patient with ectopic adrenocorticotropic hormone excess. This is a very important chart. Algorithm for management of patient with suspected Cushing syndrome, that is clinical suspicion of Cushing's which causes central adiposity, proximal myopathy, striae, amenorrhea or hirsutism, impaired glucose tolerance, diastolic hypertension and osteoporosis. Screening confirmation of diagnosis, 24-hour urinary free cortisol excretion increased above normal. Dexamethasone overnight test, plasma cortisol greater than 50 nanomole per liter at 8 to 9 am after 1 mg dexamethasone at 11 pm. Midnight plasma cortisol greater than 30 or midnight salivary cortisol greater than 5. If further confirmation is required, you to give low dose dexamethasone suppression test. You give plasma cortisol greater than 50 nanomole per liter after 0.5 mg dexamethasone 6th hourly for 2 days. If negative, the diagnosis of Cushing's is ruled out. If it is positive, you do the plasma ACTH levels to find out whether it is ACTH dependent Cushing's or ACTH independent Cushing's. So ACTH suppressed. So ACTH is suppressed by it is less than 5 picogram per ml. So it is ACTH independent Cushing's. When ACTH is suppressed, it means that ACTH is produced peripherally and something is that peripherally produced ACTH is suppressing the pituitary. So you will have to, it is basically the disorder is in the adrenal gland. So you will do an enhanced CT of the adrenal gland. If it is bilateral micronodular or macronodular adrenal hyperplasia, you will do bilateral adrenalectomy. If it is unilateral adrenal mass, adrenal tumor workup and unilateral adrenalectomy. If ACTH is normal or high, that is ACTH independent Cushing's means what? That ACTH is produced by the pituitary tumor gland itself. So you do MRI pituitary or you will do CRH test, corticotropin releasing hormones stimulation test. ACTH increases greater than 40% at 15 to 30 minutes plus cortisol increases greater than 20% at 45 to 60 minutes after cortico releasing hormone 100 microgram IV. Or you can do a high dose dexamethasone test where cortisol suppression of greater than 50% after 6 hourly 2 mg dexamethasone for 2 days. It will result in three things. If CRH test and high dose dexamethasone test is positive, there is Cushing's disease. Means what? The disease is in the pituitary. So you will do a transsphenoidal pituitary surgery. If it is equifocal, then you will do inferior petrosal sinus sampling. When ACTH ratio, when the petrosal peripheral ACTH ratio is greater than 2 at baseline or greater than 3 at 2 to 5 minutes after CRH 100 microgram IV. If it is positive, then you will do a transsphenoidal pituitary surgery. If it is negative, locate and remove ectopic ACTH source. If you are not able to do that, then you will do bilateral adrenalectomy. So this is the basic workup of the Cushing syndrome. Signs and symptoms of adrenal insufficiency. Signs and symptoms caused by glucocorticoid deficiency, that is fatigue, lack of energy, weight loss and anorexia, myalgia, joint pain, fever, normochromic anemia, lymphocytosis and eosinophilia, slightly increased TSH due to loss of feedback inhibition of TSH release, hypoglycemia, low blood pressure, that is postural hypotension, hyponatremia due to loss of feedback inhibition of EVP release. Signs and symptoms caused by mineralocorticoid deficiency, primary adrenal insufficiency only. It causes abdominal pain, nausea and vomiting, dizziness, postural hypotension, salt craving, low blood pressure, postural hypotension, increased serum creatinine due to volume depletion, hyponatremia and hyperkalemia. Signs and symptoms caused by adrenal androgen deficiency. It causes lack of energy, dry and itchy skin in women, loss of libido in women, loss of axillary and pubic hair in women. Other signs and symptoms, it causes hypopigmentation, primary adrenal insufficiency only due to excess of pro-opioid melanocortin derived peptides, alabaster colored pale skin, secondary adrenal insufficiency only due to deficiency of POMC derived peptides. So these are the clinical features of adrenal insufficiency. Algorithm for the management of patient with suspected adrenal insufficiency. Clinical suspicion for adrenal insufficiency when the patient comes with weight loss, fatigue, postural hypotension, hyperpigmentation, and hyponatremia. Screening confirmation of diagnosis when plasma cortisol is 30 to 60 minutes after 250 microgram. Concenotropin, IM or IV. Cortisol post concenotropin is less than 450 to 500. CBC serum, sodium, potassium, creatinine, and urea and TSH. Differential diagnosis due to plasma ACTH, plasma renin, and serum aldosterone. Primary adrenal insufficiency when the plasma ACTH is high, that is Conn syndrome, high renin and low aldosterone. This will have normal or low renin and low ACTH in case of secondary adrenal insufficiency. In secondary adrenal insufficiency, you will do glucocorticoid replacement. You will do MRI pituitary. If MRI pituitary is positive, then do hypothalamic pituitary mass lesion. If it's negative, history of exogenous glucocorticoid treatment, primary head trauma, history of head trauma, consider isolated ACTH insufficiency. If after replacing glucocorticoid and mineralocorticoid, there is adrenal autoantibodies, they are positive, then it is autoimmune adrenalitis or autoimmune polyglandular syndrome. If it's negative, do a chest X-ray, serum 17OH. P. In men, plasma, very long chain fatty acids, and adrenal CT. If it's positive, then it is adrenal infection, that is tuberculosis, infiltration like lymphoma, hemorrhage, or congenital adrenal hyperplasia. Autoimmune, if it's negative, then it is autoimmune adrenalitis, most likely diagnosis. In men, consider adrenoleukodystrophy. So this is the workup of adrenal insufficiency. So, algorithm for management of patients with suspected mineralocorticoid excess. There is severe hypertension, which is not controlled by more than 3 BP drugs, drug resistant, hypokalemia, adrenal mass, a family history of early onset hypertension, or cerebrovascular event less than 40 years of age. If it is negative, rule out. If it's positive, then do a screening. Measurement of aldosterone renin ratio on current blood pressure medication. Stop spironolactone for 4 weeks. Spironolactone is an antagonist for aldosterone. That's the reason we're stopping aldosterone before this test. And with hypokalemia corrected, so ARR screening positive, ARR is more than 70 picomole per liter, and aldosterone is greater than 450 picomole per liter. Consider repeat of beta blockers for 2 weeks if results are equivocal. If it's negative, it rules out SIADH. Confirmation of it rules out suspected mineralocorticoid excess. Confirmation of diagnosis, example, saline infusion test, 2 liters physiologic saline over 4 hours IV. Oral sodium loading and fludrocortisone suppression. Unenhanced city of adrenals, that is unilateral adrenal mass. If age is less than 40 years, unilateral adrenalectomy. If age is greater than 40 years, if surgery practical, adrenal vein sampling. If it's positive, unilateral adrenalectomy. If it is negative, drug treatment. If it is bilateral micronodular hyperplasia, you do drug treatment. If it is normal adrenal morphology and family history of early onset hypertension, screen glucocorticoid, remediable glucoaldosteronism. If it's positive, treat with dexamethasone. If the screening is rare, both renin and aldosterone are suppressed, 24 urinary steroid profile. Diagnostic for apparent mineralocorticoid excess, CAH, adrenal tumor related deoxycortisone excess. If negative, consider Liddle syndrome. Response to amiloride trial.